I'll do is I will talk a bit about some of the successes in AI and healthcare. I'll talk a bit about what I do for research, what I do for teaching, what I do for a master's program at the school. And then I want to leave plenty of time for Q&A. So I'll try to not take too much time. I'm a teacher, so I do tend to talk a bit long at times. So I'll try to keep it as concise as I can, but as clear as I can. And if you have any burning questions, I'm totally fine answering them during the presentation. So that's also an option if you would like to. Okay, cool. Let's see. Perfect. Okay, so a little bit about me. As Min said, I'm Dr. Heather Mattie. I'm a lecturer on biostatistics, and I'm the co-director of the Health Data Science Master's Program at the Harvard T.H. Chan School of Public Health. The Health Data Science Master's Program, if you've never heard of it, it's fairly new. It only started in fall of 2017. That's when our first cohort joined us. And I've been faculty since May of 2017 and kind of co-director of the program the entire time. So my main job is to, and I'll talk about this a bit more if you'd like, but I mentor students, I advise students, I do curriculum development for the master's program, I do recruitment, I do marketing, I do pretty much anything that's needed for the students. I get a lot of help from other administrative people in the department and my other co-director, JP Onella. But so far it's a relatively young program, but it's I think really grown into something really nice. I split my time between being co-director of that master's program, teaching a few courses throughout the year, doing my own research and grant writing, and what else do I do? Diversity work at the school and the department. And so I'll talk a little bit more about my research and things in a minute. And one other thing, in case you ever have questions, I was also a PhD student in the same department. And I got my PhD in biostatistics in 2017. So I've been in the department since 2011 when I started as a grad student, and then have just stayed on as faculty. So I've been there quite a while now, over a decade. And then my research, I'll hit on these topics a little bit more in a little bit. So I'll come back to those topics. In terms of teaching, my course load has gone down a little bit this last year because my research load has gone up. But these are the main courses that I've taught at the school for the last few years. And I'll send these slides so that you guys can have these as well, so you have all the links and everything. But I really believe in having, especially teaching materials, be very open source and reproducible and usable to as many people as possible. And so these links are to GitHub repositories with all of my lectures and labs that we have for the courses and things like that. So I've taught Introduction to Data Science in R, so just basic data science, machine learning, wrangling, visualization. I've taught deep learning, reproducible data science, this capstone course that we have for the master's program instead of a thesis. In the summer, I teach collaborative data science in healthcare with a clinician who's also a professor at MIT, and that's kind of an introduction to like machine learning and R and analysis in healthcare for clinicians. I also teach kind of the Intro to Biostats course at the school, and then a new course that we're going to be offering in the fall is Core Principles of Data Science, which is exactly like the Introduction to Data Science, but a little bit less quantitative. It's a little bit more for those without a super technical background. So I teach GitHub, R, Python, a lot of those tools. Okay, so I want to start off with, and I think you guys have maybe seen some of these examples before, but some kind of success stories in public health and medicine and with AI. And as awesome and great as these things are, they are not perfect. And so a lot of my research actually focuses on how to make improvements and to make them equitable. And so we'll talk about that later on as well. And so just for example, we can now, using a picture of a lesion, for example, detect if it's cancerous or not cancerous, which will help us, or I say augment, clinical decision making in terms of treatment for patients. A lot of people think that because we have algorithms that have higher accuracy than expert like radiologists or clinicians or anyone of those positions, that our algorithms will take over for humans, but that's not what I'm about. That's not what the field is really about. It's more about offering like a second opinion, or, you know, just having the clinician kind of, I don't know, have more information about a bigger population of patients, for example. So again, augmenting clinical decision making, not replacing the actual expert in the room or the clinician. So that's one example. There's been a whole bunch, especially with medical imaging. Diabetic retinopathy is an example, chest x-rays. This paper, this algorithm, I think it's gotten even better over time. There's been like different iterations, but it can diagnose, I think, 14 different types of lung anomalies or kind of diseases. So it could be like a collapsed lung, it could be a nodule in the lung, other things like that, or it could be just something that's normal. And so they've actually used something like this to diagnose patients with COVID-19 versus like pneumonia or bronchitis or some other kind of chest illness. There's also been advances in time series prediction. And so a lot of times, if you also, jumping back in. All right, so it was really cool that somebody's working on TB, because I don't work on TB, but there's been really cool papers that have come out as well, using different genome sequencing data and AI algorithms and helping find different drug resistance status with, sorry, I'm very distracted, making sure nobody's taking the screen. Finding drug resistant status from using a genome sequencing data. So it really helps if you can know that a certain treatment will or won't work right off the bat, especially for something like TB. And so beyond TB and just in general, personalized medicine is becoming more of a thing now because of advances in AI and healthcare and medicine. Okay. Another really great thing, and I get to work with a lot of the people involved with these initiatives, is the kind of breakthrough we've had with actually making a lot of the data available public so that researchers can use it. Medical and health data, right, is very tricky because you have a lot of privacy, as you should, a lot of privacy laws and restrictions on how you share the data, who you share it with, what you share, all of these things. And so, but in order to make advances in the field, we need data. There's a bunch of now bigger databases of electronic medical records. Two of these things that I just want to point out are kind of Mimic and the EICU Collaborative Research Database. I've worked with both, I've published papers with both, and there's just a ton of data and information available through those two databases. You do have to use them for research. It can't just be like a personal dive into the data, and people are screened before they're given access. But there's been just hundreds of papers published, and a lot of insights gained from opening up these data sets in a safe way as well, so that people aren't identifiable. We've also had a couple of really nice, onto the question in 1 second, really nice textbooks come out recently as well with more of these advances in healthcare and medicine. Yes, there is a way to apply to get access. If you, I don't have the link here, I should have, sorry. If you Google Mimic 4 or Mimic Open Database, it will probably pop up as one of the first things. It's through the MIT Critical Care group, and then there's a link for you to actually apply to be able to download and access the data. Okay, so there's a ton more. I'm not a clinician. I'm not, clinically trained or medically trained. So I come from more the quantitative side of these things. So there's definitely much, much more that's happened in the entire field. But I'm going to focus on now a little bit of what I do, kind of with my research, and also the kind of challenges that have come up, the barriers that have come up, and I think where the field is kind of going and what the field. So my dissertation research was on network science, and specifically, how do I model relationships and the strength of a relationship between two people so that I can simulate how a virus or a pathogen will spread throughout the population, and who will be affected by it. Are there really connected people that will spread it rapidly? We call those hubs. Are there people who will spread it from one kind of densely connected community to another community, things like that. And so I did a little bit of what we call tie strength research. So again, kind of predicting how strong of a relationship you have with someone during my PhD research. And now I'm working on kind of mechanistic models and specifically for HIV/AIDS, that trying to find a way. We have kind of empirical data. So meaning we have real data sets, network data from individuals with HIV or individuals who have relationships with people with HIV. And because of the sampling process, we don't have the full network. We only see a partial bit of the network. And to really do the best at prediction and simulating how a disease will spread throughout a population, it would be ideal if you had the entire network to work with. But we usually don't. And so what we're trying to figure out now is, are there ways to model individual behavior using these mechanistic models of networks that will give rise to the structure and the connections that we actually see in a real life network? And then if we can get that kind of structure and that kind of mechanism correct, we can then simulate with a lot more accuracy how a disease will spread, how interventions will affect the spread of the disease, and things like that. And HIV is such a complex disease. There's behavioral interventions, there's medical interventions, there's prevention interventions. So these networks that are based on individual behavior, but that individual behavior affects the whole network or community, can get very complicated. And so our models are getting more complicated. They need more data. They need more algorithms and computing power. And so this is kind of one area, bigger area that I focus on. And I can talk more about that later if you'd like. Another huge area that I focus on a lot with research is health disparities. And so, especially if you're from the United States, you know, or even if you're not, but the United States is kind of infamous for having a fairly bad, not great healthcare model, in that we have a lot of disparities between certain populations of people. And so because a lot of healthcare can be very expensive, we have different groups getting access to care more easily and different groups that are not. And so the disease burden is kind of, it's not equally distributed across different populations. Typically, we see this around racial lines, with racial minorities having more disease burden and less access to care. But it can be across other lines as well. It could be type of disease, like HIV/AIDS is it's kind of there's a stigma attached to it. So those living with HIV/AIDS are also disadvantaged. And there's a bunch of different other groups as well. It just depends on how they're affected. And so what I try to do is, with my research, pinpoint the causes of these disparities and then come up with solutions that will kind of mitigate these disparities or make them a little bit less unequal between groups. And I think what COVID-19 did was really shine a spotlight on medicine and healthcare in general, especially in the United States, about how inequitable it was, especially for across racial lines, but it could be in terms of, you know, the type of job you had, if you're going to be exposed to COVID-19 more often. And so, you know, your social economic status, you could be disadvantaged because of that. You could be disadvantaged because of the neighborhood you live in, the, you know, access to healthcare and all of these things. So health disparities has always been an issue. But I think COVID-19 really kind of made it visible to everyone, even outside of the kind of medical and public health profession. And we don't just see this with COVID-19. I give a couple of other examples. We see this with hypertension is this example, but across the board, other diseases as well. There's just a higher prevalence of these diseases for certain groups. And it doesn't have to do with genetics. It has to do with kind of societal issues. So for health disparities in general, how do we actually go about fixing these things? We really need to narrow the gap in treatment. So we need to treat everyone, or we need to lower the barrier to access of care for everyone globally, but especially in the United States. It's kind of where I focus. And not only that, but the quality of treatment. There, unfortunately, have been studies where different populations will get a different quality of treatment based on the color of their skin or religious beliefs or sexual identity. And that's been terrible, but at least we know that it's happening, and hopefully we can find ways to diminish that. Other barriers, there's mistrust of the system, which rightfully so. There's stigma, there's transportation, again, access to care issues, even technology access. A lot of healthcare startups especially are coming out with like apps, the smartphone apps, to more easily access healthcare professionals in a cheaper way, maybe even a free way for certain patients with a certain health insurance. But you have to have the technology to get that app and have that access. And so it works well in some cases, but not so well in other cases. Some people still don't have a computer at home or easy access to a computer, or they work very long hours and they can't make it to different clinics or the hospital or to see different kinds of physicians. And it really also differs based on region and then your subpopulation. And so more rural populations, it's a lot harder usually to even get transportation to healthcare site, and that can lead to worse outcomes as well. We also need, and this was again really highlighted during the pandemic, better health information communication. Healthcare professionals in general, I don't want to say in general, but we're really great talking to other healthcare professionals or other people in the field. Because we know the jargon and we kind of understand a little bit, about whatever. We're not a little bit. We're like, what am I trying to say? A little bit about whatever field they're trying to chat about us with, chat with us about, but trying to relay research, insights, and results to the general public has proven to be a challenge. I struggle with it, and I actually try to teach better communication to my students. And even especially if you're like have a quantitative background, it's can be a little bit more difficult because you're used to talking in numbers and graphs and things, and so having better communication for the general public is another thing that we learned from the pandemic that we need to improve upon. And so I think that's actually becoming part of our curriculum for more of our degree programs as well. And also training of researchers, how to, communicate your research in a better way. All right. Sorry, I wasn't checking the chat, so I'll get back to your questions after all of this. How do we kind of leverage data science or AI research to kind of help with these health disparities and these kind of gaps in healthcare and medicine? There's a few ways. And so linking, like I kind of mentioned this before with the different databases that are now available, but we need to link clinical data and demographic data and genetic data, basically all these different types of data. If we could link them together, we would have a more fuller picture of an actual individual and how they relate to other individuals in that particular group or society. This could lead more to, insights on why certain populations are more at risk for some disease, if it's not just a societal thing, but maybe it is. Maybe it's a genetic thing. Why some individuals will respond better to a treatment versus others, which could help with precision medicine. So personalizing your treatment to make sure that it will work the best for you. And then treating individuals equally, regardless of what they look like or where they come from, holistically, and as an entire person, and kind of seeing the patient as an entire person and not just a list of symptoms that they come to you with. There's this really, it's still going on actually, but there was this project we had. So I partnered with people at Arizona State University and UC Merced, so University of California, Merced. when my friend, who's also a collaborator in public health, went home to the Central Valley of California, he's Latino, his parents were immigrants. And when he went back to his community, this is also a rural community, he found that during the pandemic, so late 2020, a lot of his community members were mistrustful of any health information they were getting from the news and only trusted what kind of the elders of the community were supporting. And there was this notion of vaccine hesitancy, because at the time we didn't have a vaccine yet. And so he asked them, like, if we did have one, would you get it? And they were really hesitant to get one. And so this is going back to the communication issue we have, especially around COVID-19. And so what he did was, and what we did with other collaborators, was come up with this COVID health animation project targeted to the Latinx community, where we made posters and pamphlets and websites and videos that would relay reliable health information, specifically about COVID-19, and then now the vaccines that are available, but in a way that was easy to understand, and hopefully kind of build up that trust between public health professionals and that community specifically. So that seems to be pretty successful there, especially in the Central Valley where he was from. Vaccine uptake has been really high, but we've learned from it as well. And so we've gathered data as well about hesitancy and mistrust, and we're writing papers about that now. Sorry, this is actually from our data set. So vaccine acceptance for the preliminary results was that more people in it. We had a sample. Sorry, I should step back. We sampled people from Arizona and California. For this particular kind of data set, it was a survey, and a greater proportion of those from Arizona said that they would get the vaccine than from California. And so we're trying to dig into if there's state differences, so geographical differences between them. And then we also saw that many more young people, this is kind of a more difficult plot to look at, but many more young people were hesitant about the vaccine than older people were, which we thought was kind of interesting. So again, we're still looking into that and getting insights from that study, and hopefully we'll publish on that soon. All right, I'm going to wrap up so we have time for questions. Couple of other things. I've looked into unhealthy weight control behaviors for those who use dating apps. This was another survey that we did, and finding that homosexual and bisexual men tend to engage in unhealthy weight control behaviors more, and seeing if there's a way that we can target that group specifically for more information or ways to kind of mitigate those types of behaviors. All right, and then for challenges, and I got into this a little bit before, we have these what we call data silos. And so when I said we need to like combine different forms of data, like genetic data, demographic data, clinical data, they're all housed in completely separate places that are not accessible to researchers typically. Like you'll have access to one type of data, but not the other, or it's really difficult to get the other types of data. So what we need to do is kind of tear down those silos and share all different types of data with different researchers. Another issue is that a lot of the data is not in the same format, and so we're going to need AI and data science to clean that data and make it usable. And that sounds great and easy. It's the toughest part of my job, is getting the data into that usable format. And then there's this other notion that I do research on too called algorithmic bias. And so once we have the data, we create this algorithm to help with clinical decision making, and we think it's all great. What happens if that algorithm performs better for one group over another? That's an issue, especially if there's already a health disparity there without the algorithm, just in clinical care itself. And so we have to be very careful that, especially in healthcare and medicine, our algorithms are not exacerbating the disparities between different groups that already exist. And so we wrote a paper kind of defining algorithmic bias for healthcare and medicine, or health systems in general. There's been a couple of new papers about how a lot of our research and like these thresholds for stages of disease are based on cohorts of white men, middle-aged white men from 60 years ago. And we don't actually know if they apply to women or people of color or other groups. And so we're kind of just now discovering issues with algorithms or the tools that we use for clinical decision making, and figuring out if they work for everyone or if they don't. And if they don't, how do we rewrite them? So we have a couple of papers about that as well. All right, path forward, diversify our data. I hit a little bit on this, but especially with genome sequencing, 80% of the genomes that were sequenced in the early 2000s to the 2010s-ish were from Caucasian individuals. And those variants were, the reason we want to sequence those genomes is to see how they differ between people. And so did not get a lot of information from such a homogeneous population of individuals. So we need to diversify our data, standardize how data is collected and stored so we can use them across platforms and research teams, share our data science tools and validate those tools. I'm a huge supporter of reproducibility, transparency, and then in general, not only diversifying the data, but diversifying the field as well. So instead of having very homogeneous groups of researchers, getting many different types of individuals on a team, because everybody experiences the world differently through their own lens and their own experiences and expertise. And so having a very diverse team helps make really great breakthroughs in these fields. All right, one other thing, I'm on my, last slide here. The main person who puts this on is MIT and the clinical care and mimic team, who I collaborate with a lot. But basically we put on datathons all over the world. And so we bring students and faculty from MIT and Harvard, and we travel to different countries, meet with their ministers of health and health policymakers and clinicians there. And we actually use these databases to do an analysis in like 3 days with data scientists and clinicians together, and so that we can form these collaborations and try to find new projects or new papers to write using the data that we have, because there's so many different things that you can write about. So what we're trying to do is expose clinicians to how data scientists work and how to come up with a question that we can answer with our data. And we're trying to expose data scientists to working with clinicians and have that kind of medical background and healthcare background. Healthcare background and knowledge and expertise kind of work together. So I've only been to 3 of them, but they do at least 12 a year, I think. I can't travel that much. So always a great opportunity. Okay. there's my email. Feel free to email me if you have any questions or if you want to know more, especially about the master's program that we have, or any of the research that I do. And then again, I'll send these slides over so you have the links to these dashboards and websites and things. All right.